Hello everyone, this is Dr. Richa. In this video, we will talk about calcium channel blockers. So as the name suggests, calcium channel blockers, these drugs block the calcium channels. And these calcium channel blockers are broadly classified into two types. One, non-dihydropyridines and the other dihydropyridines based on their chemical nature. So in the non-dihydropyrimidines, we have two drugs basically, that is verapamil and diltiazem. Okay, and in dihydropyridines there is a huge list, but we will mainly talk about amlodipine, then nifedipine, nimodipine, nicardipine and felodipine. Okay, so all of these end in dipine word. Dihydropyridines end in dipine. Amlodipine, nifedipine, nimodipine, nicardipine and felodipine. Now, these two classes of drugs differ in their way of action. So you see that here I have drawn mainly heart and their action potential, and here this is a schematic diagram showing the wall of the blood vessels. Okay. So non-dihydropyridine drugs act both on heart and the blood vessels, while dihydropyridines act mainly on the smooth muscles, that is the blood vessels and other smooth muscles as well. Okay, so let us first see these non-DHPs. So here I have drawn small heart with the conducting pathway, and why we have drawn two different types of action potential, because this is the action potential of the autorhythmic cells, that is SA node and AV node, and this is the action potential of the contractile cells, that is atrial and ventricular contractile cells. Now, if you remember the ionic basis of action potential, this SA node and AV node action potential, they occur due to the opening of HCN channel, T-type calcium channel and L-type calcium channel. So this is the phase 4, that is the pre-potential phase, that occurs initially due to the opening of HCN channels, then T-type calcium channels open, and this one, the phase 0, that is the phase of depolarization, occurs due to opening of L-type calcium channels. On the other hand, the action potential of the atrial and ventricular muscle cell, this phase 0 occurs due to the opening of sodium channels. Then there is phase of early repolarization, which is due to the opening of potassium channels, and this phase, the plateau phase, here the potassium channels are also open and L-type calcium channels are also open. Okay, potassium moves out and calcium moves within the ventricular muscle cell. So what we see that in SA node, AV node, this phase 0 is due to the L-type calcium channel, and in atrial and ventricular muscle cell, this plateau phase is due to L-type calcium channels. And when we talk about calcium channel blockers, they block mainly this L-type calcium channels. There are various other types of calcium channels, but calcium channel blockers block which type of channels? It is L-type calcium channels. So what will happen that if L-type calcium channels are blocked, then this phase it will be very slow. Okay, so it will become like this. The slope will be much slower, and this also L-type calcium channel blocks. That means calcium is not going to enter the ventricular muscle cell. And when we talk about cardiac muscle cell, this calcium entry within the ventricular cell during the action potential causes release of more calcium from the endoplasmic reticulum. Okay, so this calcium is causing more calcium release, and this is important for contraction, both extracellular calcium which enters and the calcium which is released from the sarcoplasmic reticulum. So if this calcium doesn't enter, there will be less intracellular calcium and there will be less contraction. So overall we can say that it decreases the heart rate and decreases the conductivity. Why? Because this type of action potential, it is occurring in SA node, and SA node is the pacemaker of the heart. So when less calcium enters, this impulse generation will be decreased. This will decrease the heart rate, and autorhythmic cell other also will be affected. So here conduction will be affected. So it decreases the heart rate and also decreases the conductivity. Okay, so we call it like decreased chronotropy, decreased dromotropy. Right. Now here also it is affecting, that is in the contractile cells. So what will be the effect? There will be decrease in the contractility as well. Okay. So that was the action on the heart. What about the action on the smooth muscle of the blood vessel cells? I told you that these two drugs also act on the smooth muscle of the blood vessels, but DHPs are more selective for the vessels. They do not act on heart, they act only on the vessels. Okay, so in vessels, here this is the endothelial lining and this is the smooth muscle cell. So what happens that whenever there is any stimulus for contraction, say suppose adrenaline is there, so ultimately there is increase in the calcium within the smooth muscle cell. And smooth muscle cell basic mechanism of contraction is that calcium combines with calmodulin, another protein, and this calcium calmodulin activates the myosin light chain kinase. Kinase means it is going to phosphorylate any protein, and this is myosin light chain kinase. So this kinase is going to phosphorylate the myosin light chain which is present in the myosin. Okay, so this activates the myosin and there is actin myosin interaction which is important for contraction. So the smooth muscle is going to contract because of this. Now we said that we are blocking the calcium channels. So these DHPs are going to block this calcium channels. Again, these are L-type calcium channels. So when they are blocked, this is going to lead to smooth muscle relaxation. Okay, smooth muscle relaxation. And whenever there is dilation or the smooth muscle relaxation in the blood vessels, this is going to lead to vasodilation. Okay, so the diameter of these blood vessels is going to increase and this leads to decrease in peripheral resistance. Okay, diameter is increasing, resistance to blood flow is going to decrease, and peripheral resistance is a determinant of blood pressure. Two determinants of blood pressure are there, that is cardiac output and peripheral resistance. So peripheral resistance decreases, blood pressure decreases. Okay, so this decreases the blood pressure. Fine. So this is the action on the smooth muscles of the blood vessels and this is the action on the heart. Okay. Now before I proceed, just want to let you know that here whenever there will be decrease in the blood pressure, body will try to correct it. How it tries to correct it? By activating the baroreflex. So if baroreflex is activated, there will be action on the heart. There will be increase in the sympathetic activity and there will be increase in the heart rate. Okay, so this is the compensatory mechanism which happens by the body due to the baroreflex. Okay, now based on this action, we will talk about what are the indications, what are the adverse effects and contraindications. Okay, I hope you have understood this. Simple, remember that verapamil, diltiazem act both on heart and the blood vessels. Diltiazem is kind of intermediate. Okay, so the action on the heart is lesser than the verapamil and action on the blood vessels is lesser than the DHPs. Strongest action on the heart is of verapamil. DHPs are vasoselective, they are acting only on the blood vessels. I mean it is on the smooth muscles, other smooth muscles also they act, but they don't act on the heart. Fine. So let us come back to indications. What will be the indications of these verapamil and diltiazem? See, I told you that they are mainly acting on the heart. So if we talk about their indication, what will be the indications? They are decreasing the heart rate, they are decreasing the conductivity. So they will be used in conditions in which heart rate is more, conductivity is more. Okay, so they are used in arrhythmias. And which arrhythmias? They are used in paroxysmal supraventricular tachycardia and to decrease the ventricular rate. Decrease the ventricular rate, not venous return. This is ventricular rate. Okay, in case of atrial fibrillation and atrial flutter. Why? Because they are decreasing the conductivity. So if the impulses in the atria are more, decreased conductivity will cause decrease in the ventricular rate. Okay. Then other indication is HOCM. Okay. Hypertrophic obstructive cardiomyopathy. Then since they are acting on blood vessels as well, other indication is hypertension. Right. Moving on to DHPs, what will be their indications? They will be used, you see, their main action is decrease in the blood pressure. So main use will be hypertension. Okay, so that is one use. And this amlodipine is the most preferred drug for hypertension. Why? Because very important that you see, I told you that this is compensatory increase in the heart rate which is going to occur with the use of DHPs. But amlodipine, because it is slow acting and long duration acting, so slow acting and long duration acting, this reflex increase in heart rate is lesser. This is reflex tachycardia, that is lesser. So that is why amlodipine is preferred, most popular drug also for hypertension. Okay, because you see, when heart rate is going to increase, the work done by the heart, it is going to increase, and there will be increased oxygen consumption by the heart, that we don't want. Okay, so that is one. Then apart from the systemic blood vessels, they also dilate other vessels. In fact, this nimodipine is cerebroselective. That means it dilates the blood vessels of the brain. Okay, and that is why it is used in subarachnoid hemorrhage. In subarachnoid hemorrhage, there is a reactive vasospasm of the cerebral vessels. So that also can be damaging, okay, because vasospasm, it is going to decrease the blood supply further. So in that case, nimodipine is preferred. Remember that it is cerebroselective, right? Then we have felodipine. Felodipine has been approved for Raynaud's phenomena. In Raynaud's phenomena, what happens? Raynaud's phenomena, when there is exposure to coal, there is vasospasm. Vasospasms will be so severe, can be so severe that it can lead to ischemia, ultimately cyanosis, because there is decrease in the blood supply. So felodipine has been approved for Raynaud's disease, right? Then we have nicardipine. Nicardipine is IV drug used for hypertensive emergencies. Okay, IV drug used for hypertensive emergencies. So these are short acting drugs, but when we talk about IV drug, then in that case, this nicardipine is longest acting IV drug. Okay, longest acting IV drug. It is short acting, but among the IV drugs, it is longest acting. Okay, so these are the various uses of DHPs, and here non-DHPs, I told you that it is used mainly for the arrhythmias. Then these DHPs are also used for Prinzmetal angina. What is Prinzmetal angina? This is the variant angina. That is, if the angina is occurring due to the vasospasm of the coronary vessels, there is not any plaque which has formed, but the coronary vessels are going vasospasm. Okay, so there is a constriction of the coronary vessels, so the diameter is decreasing, hence there is decrease in the blood flow. So in that case, these CCBs can be used in Prinzmetal angina. Prinzmetal angina, they are the preferred drugs. In fact, they can be used in classical angina also, but only when beta blockers are not tolerated by the patient or they are contraindicated. So in that case, CCBs can be used. Now moving on to what are the adverse effects and contraindications. Can you tell by this mechanism of action what will be the adverse effects of non-DHPs? They are decreasing the heart rate, okay? They are decreasing the conductivity. So adverse effect can be decrease in the cardiac output. Okay, but remember, this decrease in the cardiac output doesn't occur in all conditions, but is important in case of CHF patients. Okay, so that's why the calcium channel blockers are not used in CHF because of their tendency to cause decrease in the cardiac output. Fine. Then most common side effect of all these drugs is constipation. Constipation. I told you that they are relaxing the smooth muscles of other organs as well, not only blood vessels. So most common and obviously unliked complication is constipation, right? Then contraindications, these drugs, non-DHPs, should not be used with beta blockers. Why? Because beta blockers also decrease heart rate, they also decrease the conductivity, so they are not used along with the beta blockers. Then they are also not used post-MI. Post-MI they should not be used because they increase the mortality. Again, why? Because there is tendency to increase the heart rate. Now, if heart rate increases, that is bad because as I told you that there will be increase in the oxygen consumption. However, that tendency to increase is lesser with verapamil and diltiazem because both of these are acting on the heart. They are depressing the heart rate also and conductivity also. So this increase in heart rate, which is happening reflexly due to decrease in blood pressure, is counteracted by the direct effect of these drugs on the heart. So this effect on heart rate is not much with verapamil and diltiazem. In fact, verapamil causes decreased heart rate only. Overall effect is decrease in the heart rate because of more effect on the heart. But still, post MI, these drugs are not used because they increase the mortality. Both non-DHPs and DHPs are not used. Then any other contraindication? See, they are decreasing the conductivity, decreasing heart rate. So if there is sick sinus syndrome, because already this will cause bradycardia, sick sinus syndrome, then they should not be used. They should not be used in presence of AV block. AV block means already conductivity is less and you are going to further decrease the conductivity by use of these drugs. So don't use in case of sick sinus syndrome and AV block, otherwise full AV block can precipitate. Fine. Then moving on to some side effects of DHPs, I told you most common side effect because of the smooth muscle relaxation is constipation. With amlodipine, there can be another side effect as well, that is ankle edema, because this is the most commonly used drug for hypertension. So that is why we should be careful that yes, patients may complain of ankle edema, and this happens because the capillaries, these are the capillaries, say suppose, here there are venules. So there is constriction of these post capillary venules. So if they constrict, what is going to happen? The blood will not flow. It will flow less from the capillaries to the venules. So it will jam up here in the capillaries. So what is going to happen? This is going to increase the hydrostatic pressure in the capillaries. Right? Increased hydrostatic pressure means that more fluid will move out of the capillaries. That is the Starling's forces. Okay? Hydrostatic pressure increase means that it causes the fluid movement out of the capillaries. So that is going to cause ankle edema. So that was about the calcium channel blockers. So if I have to summarize, what will I say? That yes, there are two types, non-DHPs, DHPs. Non-DHPs act on heart as well as the blood vessels. DHPs act mainly on the blood vessels. Then we have seen that the adverse effects and contraindications, if we understand the action itself, we can predict what will be the adverse effects and what are the contraindications. Remember that they should not be used with beta blockers. They should not be used in sick sinus syndrome and in AV block. And they should also be not be used post MI. Okay, then very important thing, then when they should be used. So in angina they can be used if beta blockers are contraindicated. Okay, in hypertension also now there are other drugs, ACE inhibitors and ARBs, which are preferred. So if there are contraindications for that, then these calcium channels can be used and they are the preferred drugs in elderly. In pregnancy also they are safe. ACE inhibitors and ARBs, they are fetopathic. They cause congenital malformations. So in pregnancy also these calcium channels are safe. Then in low renin hypertension also these can be used. Then in patients on whom beta blockers are contraindicated, as I told you, that if the patients are having asthma, then in that case beta blockers are not used for them. So in that case calcium channel blockers can be used, and also they can be used for peripheral vascular diseases. Fine. So that was all about the calcium channel blockers. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and do subscribe to the channel Physiology Open. Thank you.